Hi, I want to take just a few moments to explain the pathophysiology of diabetic ketoacidosis. You should have already read about this in your textbook and also seen some of the PowerPoints that are posted in your class regarding diabetic ketoacidosis. So this should be pretty much of a review for you. Okay, so let's look at what happens when a patient develops DKA. The first thing, of course, is that a patient that is going into DKA is usually a type 1 diabetic who's not producing any insulin at all. And so the patient's blood sugar is going to rise. Patients with DKA often have blood sugars over 400. It may be 500. It may even be 800 plus. It can be really, really high. Remember, normal fasting blood sugars are 70 to 110, and patients who are running blood sugars over 130 are diagnosed with some kind of diabetes. Okay? So as this patient's blood sugar rises, the cells are still not getting any glucose, right? Because there's absolutely no insulin to unlock the cell. No, the key of insulin is not present, and so there is not any glucose moving into the cells. This puts the cells in a state of starvation. Your patient may be losing weight, and your patient may have what we would call polyphagia. They can become very, very hungry as the body cells keep telling the brain, we don't have enough glucose, we have no energy, we don't have enough glucose. So the patient may have what we call polyphagia, a really large increased appetite. However, they still aren't gaining weight and the cells are still starving. The other thing that begins to happen is that as the sugar in the blood rises, that there's a larger and larger amount of these large sugar molecules in the blood that will begin to spill over into the urine as the blood is perfusing the kidneys. Sugar is not supposed to be found in our urine. So the other thing that will happen because of that is that these large cells also start pulling water through the process of osmosis, which you have been exposed to before, and we'll talk about in some other classes dealing with fluids and electrolytes. But these large sugar molecules that are spilling over into the urine are also pulling a lot of water with them. So the patient becomes also very dehydrated. And what symptom would we all have as we're beginning to be dehydrated is that our thirst is going to increase tremendously. So these patients are drinking lots and lots and lots of water. We would call that polydipsia. So we have the polyuria, which is the fact that your patient is voiding a large amount of urine. We have polydipsia in that the patient is extremely thirsty. And we also have polyphagia where the patient is hungry. And all of this is related to high blood sugars and a lack of glucose in the cells. So when we talk about the 3 Ps, we're talking about polydipsia, polyphagia, polyuria. Other kinds of things also begin to happen to your patient. One is as the body is literally screaming for energy, the body is going to start breaking down fat and even muscle in order to use ketones for energy. So that patient goes into a ketoacidosis, meaning the pH in the blood actually drops and the patient becomes very acidotic. This process actually, again, can happen very quickly. You may have a patient that is near death within 24 to 48 hours with in the absence of treatment for diabetes, in the absence of insulin, because receiving insulin is in the end the only thing that is really going to solve this patient's problem. There are other things that you will find physicians ordering, like increased fluid, and they'll be doing things to manage the fluid and electrolyte balance. But essentially, that patient must have insulin in order to survive. These patients will become comatose if it goes on further, and also they can become confused maybe before that. What are some of the other symptoms that the nurse might find? You may find that your patient has what we call Kussmaul breathing. So that's this very, very deep, rapid, labored respiratory pattern that the patient can go into. And the purpose of that, of course, is to get rid of acid. So when a patient is acidotic, the respiratory system can become a compensatory mechanism and try and help that patient breathe off more acid. We haven't talked about arterial blood gases yet, but you will learn that carbon dioxide, which is what we breathe off, we would consider that acid. And so you have a respiratory system that is trying to get rid of as much acid as possible in order to bring the pH back up to what would be normal. Okay, so this patient has, let's review at this point, this patient has increased blood sugars, they have polyuria, increased urine, they have polydipsia, extreme thirst, they may be losing weight, they may have they'll have polyphagia where they are extremely hungry. Remember, the cells aren't getting the glucose from the blood. The ketones will circulating in the blood will affect the brain, and so you have a patient who can become increasingly confused and then eventually comatose. What is the breath of that patient going to smell like? They're breathing off all this acid, and so they have what we might call a fruity smell to their breath. Once you smell it, you will always recognize that is a patient with this fruity ketone kind of smelling breath. You won't forget the smell. It's that distinctive. Now, without any treatment at all, the patient will die. All right, and so before the advent of the administration of insulin, these were children that did pass away from diabetic ketoacidosis. Of course, today, if someone gets help soon enough, it often can be taken care of in the hospital. Often these patients can be put into intensive care units. They may be given insulin drips where they actually have their blood sugars checked every 10 or 15 minutes, and through an IV, they're receiving a prescribed dose of insulin based on what their blood sugars are. Well, basically that's it. Please remember the 3 P's. Remember Kussmaul breathing. Remember the acid, fruity smelling breath. Remember your 3 P's. And I think you probably should do okay on your test.